In this research, we expose splinting the vascular access in vascular access-related infection in hemodialysis patients in order to preserve the vascular access. As we know, vascular access infection in hemodialysis patients is the number one cause of morbidity in this population. In Mexico, patients in hemodialysis many times are unable to get a fistula because of lack of human and material resources. So that's why preserving the vascular access is so important to us. Our objective is to demonstrate that splinting the vascular access is an appropriate method to preserve the vascular access in hemodialysis patients with vascular access-related infection. This is a pilot-type controlled clinical trial. We admitted 9 patients with chronic kidney disease on hemodialysis with catheter-related bacteremia. Our outcomes were death, endocarditis, and recurrence, followed by 6 months. So, 9 patients underwent splinting of the vascular access as it follows. After asepsis and antisepsis, a flexible metallic sterile guide is introduced through the venous end of the catheter, through which the catheter is extracted. Then, through the guide, an 8th French enteral tube is introduced. An antibiotic, in this case vancomycin, is left for a minimum of 3 days. And depending on the dialysis need, the access is splinted for a period of 3 to 5 days, and the exchange is performed using the Seldinger method. In this pilot study, the mean age was 42 years, with a standard deviation of 14 years. 55% were men and 44% were women. 88% had hypertension, and the most frequent causal agent was Enterococcus cloacae, as we can see in the graphic below, with 33%. In all of the 9 patients, the recurrence of bacteremia, endocarditis, catheter dysfunction, and death was 0 at 6 months. So, we conclude that splinting of the vascular access is an alternative for the preservation of the vascular access without recurrence or increased mortality. Nevertheless, because this is a pilot study, a larger sample is needed to evaluate other possible outcomes.